Hello, this is the American Medical Association's COVID-19 update. This is part one of a two-part series where we're talking to three healthcare leaders in New York about lessons they learned in one of the nation's first hotspots. I'm joined today by Dr. Mark Jarrett, Senior Vice President and Chief Quality Officer, as well as Deputy Chief Medical Officer at Northwell in New York. Ramon Rodriguez, President and CEO of Wyckoff Heights Medical Center in Brooklyn, New York. And Dr. Eric Way, Senior Vice President and Chief Quality Officer for New York Plus Health Hospitals in New York. I'm Todd Unger, AMA's Chief Experience Officer in Chicago. Uh, let's look back 6 months and talk about how you prepared as it became clear there would be a surge of COVID-19 cases in New York. That is, if you had time to prepare. When you think about that, Dr. Jarrett, what in that preparation worked and what didn't?
So the thing that worked in that preparation time was immediately standing up our emergency operations center and going to a full incident command system to bring in all the resources we have in the system, which thankfully were quite extensive, and also due to our experience being in New York, to bring it together so we can both attack the problems that were going on at the time, but also plan for what was going to be expected would happen over the next several weeks to a month. What I thought we didn't expect was how rapidly this was going to go from 0 to 60 in terms of an event. Where, as you know, our first patient was admitted in the first week of March, and by the middle of April, we had over 3,500 patients admitted to our hospitals with 800 plus on ventilators.
Dr. Jarrett, I was just interviewing the team that made the documentary They Get Brave and illustrated that very point. And one of the hospitals they did feature was Northwell one. Dr. Way, what do you think about in terms of preparation or what worked and didn't work?
Yeah. So I think what works similarly standing up our incident command structure, our Tiger Team calls, and our president and CEO, Dr. Mitch Katz, challenged each of our facility CEOs and their leadership. What would happen if 75 ILI patients showed up at your front door in your emergency department today? And so doing some of those tabletop exercises certainly helped us. But similar to as Dr. Jarrett mentioned, we had our first case on March 6th, and then it was no longer a tabletop exercise. It just blew up. And so I think one of the things that stands out that didn't work was thinking that this was something like Ebola that you could ask certain questions for and screen and isolate patients and put them in isolation rooms. And I just remember early on shift trying to ask questions to screen for chances of COVID, and then realizing that it was such a futile effort, and being surprised by trauma is coming in. You put them in a CT scanner and they have ground glass capacities in their lungs. Ankle sprains coming in, and they had fevers and then were coughing. And so I think a hard lesson learned is just every patient was a potential COVID patient.
Mr. Rodriguez?
Well, 6 months ago, I don't think we were thinking much about what might be happening. I think the timing, 6 months before the actual incidents, things start really getting hot in December. And we are not a system. We are one hospital, a number of primary care and specialty care organizational entities around us. But we have a very close working relationship and an affiliation with Northwell. And they're good teachers, and they're very good at supporting what we needed as a safety net hospital. So we started in December with part of their organization called True North, and started doing very much the same kinds of things that were being talked about by the physicians. One thing I would say that is critical, and I wish that we had, as early as possible, started thinking about this, is the single most important problem we had was staffing. And I think that's true about a lot of places. And because of our extant position on the border of Brooklyn and Queens, we were initially the torrential downpour came with us. You've heard about Elmhurst Hospital, which is part of the health and hospital system. They were hugely overrun. Well, we're only 3 miles from there, and most of our patients, like the patients at Elmhurst, where I grew up, are Latino, or have migrated to this country, are living in situations where I may have grown up in a 1 or 2 family home, and I had 4 or 5 people living with me. The same apartment I have, there are 20 people living there. And we, as a one example, we had one family, 9 people got the virus, and they all died of one family.
So, staffing, obviously, one of the key challenges. Dr. Way, what are some of the other unexpected challenges that you encountered?
I think something that's gotten a lot of attention is obviously the PPE supply, and also just the nervousness of ventilators and running low. I think on top of a lot of this, it's just American doctors and American healthcare. You never have to make these types of decisions. Just the threat of potentially getting to a point where you have to make choices and rationing. I'm thankful we never got there, and New York City was able to flatten its curve. But we certainly learned a lot about the vulnerabilities of our supply chain for personal protective equipment, and we certainly had to rely on FEMA, the state, the federal government for ventilators. And so I think that was a big wake-up call, not just for New York City, but we're seeing it across the country and across the globe.
If I could just add to that, just a quick thing. For us, it was distribution that was a problem. For us, it was at one point we had people who had PPE envy. They were looking to get more and more and more things. We had enough, but we had a hard time making sure that it was fairly distributed throughout our little hospital. And I'm hoping that this time around we'll be more ready in the first instance if we do get a surge.
Well, let's talk about, one of the questions asked before we started taping was, how does it feel to be looking somewhat on the outside as your colleagues across the country are now in a similar hotspot situation throughout the South and the West? What are the key lessons that you want to impart to those physicians to help them battle this pandemic? Mr. Rodriguez, why don't you go first?
Well, I would say that communication between and within the organization and between families and people who are affected, it is beyond my comprehension that what's happening in Texas, Arizona, Florida, and other locations, that you can really prepare. But the most important thing is the staffing, making sure that you have the backup support of whatever state entities will be helping you, and have that communication going on a regular basis. And I think it feels daunting when you think about the locations, but with respect to the locations, you figure it out. You're able to now learn from our experience and figure it out and go forward. The PPE is a matter of making sure that you're getting it to the right place at the right time, but it's all about staffing. And we were lucky. We had people coming from Arkansas and worked with us. We had a pulmonologist that came from Arkansas and worked for 3 straight weeks, and she saved us. I mean, as one example.
I would add something else in addition to what Mr. Rodriguez said, and that's about the importance of using data.
Absolutely.
In terms of what your staffing is, in terms of what your bed capacity is, in terms of even your testing abilities. You really need the data to see both where you are, where you need to be, and we were doing this every day in terms of ventilators, as I know Dr. Wade was doing as well, looking at ventilators every day, but looking at all this and developing almost predictive models to tell you where you are on that slope up, or the slower slope going down. It's not as rapid as the uprise, but you need that because you may think you're okay, but depending where you are on the curve, you may not realize that you're going to need a heck of a lot more, whether it's staff, beds, supplies, and supplies are an issue. It's not just PPE. I mean, we had so many people who needed intensive care. We were running out of triple lumen catheters. I mean, we were running out of Foley catheters, things that you wouldn't even think about, all of a sudden become in short supply. But that's where predictive analysis and using your own data to see where you are every day and figure out where you're going to be in another 3 days, 5 days, and in a week is critical in maintaining yourself in an event like this. And it takes a while to start building up that expertise to really get that data. There's now, models out there we've developed and other people have developed it. People need to learn from that so they can really predict what they still need for the next several weeks or a month.
Dr. Jarrett's right, and we were recipients of that information. We really got a lot of help from Northwell in that process. We had to deal with it ourselves, but they assisted us. One thing that I didn't add, I want to add, the next time around, we had one code team. We were getting 10, 12 codes a day, and we couldn't keep up. So we're now dealing with setting up an A and a B and a C backup code team. And everybody who is not a critical care nurse is being in service and prepared as part of a process. And the teaching element came actually from Northwell, 2 half-day sessions that we're working on that we learned from them. So that's been very helpful. And I can't say enough about how helpful the state was. City 2 was very helpful, but I can't say enough about how helpful the state was. We never ran out of the most important aspects of our organization, the ventilators, et cetera. We had some problems with the tubing, but the ventilators, et cetera, were really helpful. And it caused us to be able to be responsive to, I think, one of the hottest spots in the whole city of New York.
Dr. Way, how about you in terms of lessons learned that you would like to impart to today's hotspots?
Yeah, so I agree 100% about data analytics and intelligence and having insight into where every ventilator and where every staff member is, and being able to move equipment and staff around to meet the need. And so sometimes we were sending in reinforcements of ventilators 2-3 times a day to hospitals like Elmhurst. And I absolutely agree that staffing is the hardest and often the last component. You can create a new surge ICU space and have the oxygen piped in and have the ventilators and all the equipment there, but without the staff, you can't bring patients in there. And so that's why we're forever grateful for the Department of Defense bringing in military healthcare personnel in to support our staff, the volunteers who came. And so it is heartbreaking seeing what's happening across the South and West in the United States. And it feels so far away. We definitely empathize with what they're going through, and our heart breaks for them. And I know another thing to add as a lesson learned, I know Northwell is a large system similar to New York City Health and Hospitals. And we felt fortunate that we were able to level load the surge across our facilities. And so not only sending staff and equipment to where the most patients are coming in the front door, but actually moving patients around. So not allowing one facility to drown. And so if we can do this all over again in the next wave, if there is one, it would be for us to work together as a city, as a state, as a region, to be able to level load across, and not just the Northwells and the health and hospitals get the advantage of doing that, but others do not.
Well, that concludes part 1 of our series. I want to thank Dr. Jarrett, Mr. Rodriguez, and Dr. Way for being here today and sharing their perspectives with us. We hope you'll join us tomorrow for part 2 of our update. In the meantime, for updated resources on COVID-19, go to ama-assn.org/COVID-19. Thanks for joining us, and please take care.